and then they have to talk into the mic to ask questions, otherwise they can't hear it. So I will pass the mic when it's question time. Test, test. Good morning. How's the volume? Not loud enough? Hold on. No, I'm going to introduce you first. How's that? Is that okay? All right. So before we get started, I just wanted to, first of all, thank you all for being here. This is going to be a very important meeting today. First, we're going to have Dr. Arthur DiNapoli, who's right here. He is our medical director here at Woodland Pond and also a practicing physician here at Woodland Pond. Dr. DiNapoli has been here since we opened 15 years ago in both roles. We work together very closely. In his role as medical director, he's responsible for ensuring that the policies and procedures that we have in place for skilled nursing specifically are medically appropriate, best practice. He's required to stay up on the regulations and the best practices and work with the next person that I'm going to introduce to make sure that our policies conform with the latest industry guidance and ensure that he's happy and satisfied with the way that we are dispatching that. He's going to speak to you first about CPR, what full code status means, some things from a medical perspective. And then the next two women that I'm going to introduce. First, Debbie Vining. Debbie is an RN. She is our highest, she's the top RN that we have. She's what's called our director of nursing. And Debbie has done this role at other facilities, and we were very happy to recruit her about a year next week. So congratulations for a year. Debbie brings an enormous amount of experience, but she is responsible ultimately for making sure that our nurses in every setting in the health center, skilled, assisted, and memory care, are adhering to the policies and procedures that they collectively, Dr. DiNapoli and Debbie, as well as Philip, introduced to Woodland Pond, and that there are no issues of concern. And to Debbie's right, on your left, is Tanya Palizzi. Tanya is our LPN nurse educator, but soon to be RN. Tanya's completing her registered nurse training as well. So like Debbie, Tanya has extensive experience in the long-term care field. She's an absolute doll. They all are. Dr. DiNapoli is the biggest doll of them all. But this is a great team of people. And what I'm extra excited about today is that today we'll give these folks an opportunity to see kind of how we do things a little bit in independent living. And we'll give you an opportunity to get to know some of the people that I work closely with from the health center. So we're going to have Dr. DiNapoli speak, take questions or comments on his portion, and then Tanya and Debbie are going to take you through what it means to have a code blue status called at Woodland Pond, which is when someone is found unconscious or unresponsive, what happens. And this is strictly for the health center. I have to make this clear. Everything we're going to be talking about from these two ladies, specific to code blue, is only health center. And then they're going to demonstrate for you the CPR process. When that happens, you're going to watch it up on the screen. And the reason is because although you see the mannequin on the table right now, properly performed CPR happens on the floor in most cases, as these ladies will explain, because you need the counter pressure, which you cannot receive from a table. But they'll get into those level of details. I'm just an actress in this regard. All right, ladies, if you want to have a seat, and we'll hand it over to Dr. DiNapoli. Doc?
Thank you.
I will take this so I can take questions.
We're talking about cardiopulmonary resuscitation. So we'll start with the cardio part is your heart. There's two things that can go amiss there. One is the electrical part of it. I think most of you have heard of or know about atrial fibrillation is an electrical disturbance that can be treated medically or electrically. And I'm betting some folks out there are treated as such. And that is a treatable condition that is manageable. There's other fibrillations. There's ventricular fibrillation. The ventricle is the lower part of the heart, and that's the chamber that does all the pumping. So if that's fibrillating, that doesn't work. That's, as we say, not compatible with life, and no blood flows through the system. And if that starts fibrillating, then you pass out, and unless you're resuscitated, that's fatal. There's ventricular tachycardia as well. That's the same chamber, only it's going very fast and still doesn't have a chance a chance to beat hard. So that's the electrical part of it. Did something change? No. That's the electrical part of it. The other part is just the pump itself. The heart's a muscle, and it has to pump to get blood flowing. So the ventricle does that pumping. Some of you may have heard of things called ejection fractions. If you have any form of heart failure, your ejection fraction may be reduced. When the ventricle does pump, I think a lot of folks have this sense that it just squeezes all the blood out. It doesn't do that. The amount that leaves the ventricle at any pump is about 60%, but some folks have lesser percent. And if you're down in the 20s or 30s, that can be a problem. And if it drops even further, then it's a real problem. Again, that's fatal. The second part of cardiopulmonary is the pulmonary part. That's your lungs. The way your lungs work are you take a breath by expanding your pulmonary cage with your chest cage with your muscles. Your chest expands and the lungs expand to fill that, and air gets sucked in. So if you have passed out, your heart stops, then your lungs aren't working either, and they obviously have to work to get oxygen into the blood, which is part of the goal of blood pumping around, is to get oxygen and nutrients. So if your lungs aren't working, then similarly can be a fatal event. The last part of that cardiopulmonary resuscitation is the resuscitation part of it. I'm bringing that up because resuscitation doesn't only mean cardiopulmonary resuscitation. Resuscitation is a verb. It means you bring back to life your plants or people or whatever. And if you're critically ill, for example, you have COVID or pneumonia, you're sick, you're not eating, you get dehydrated, delirious maybe, feverish, and you wind up in the emergency room. They will give you fluids, antibiotics if necessary, oxygen. And if you look at the ER report from that, it will say you were resuscitated, fluid resuscitation. So it doesn't have to be the kind of resuscitation we're talking about now. And the reason that I bring it up that way is I want to just reinforce that if you have a do not resuscitate order, that in no way means that nothing is done ever. So if you're in skilled nursing and you have a do not resuscitate order and somebody sees you and you're not doing well, it does not mean that we just close the door and walk away. I mean, it's still, everything is done up to what your MOLS has said you want done. I think that's important. I think a lot of folks think that if you have a DNR that we don't do anything, but that's clearly not the case. So what will happen if you have one of those electrical problems or you have a heart attack and your ejection fraction is low, then you can pass out and you wind up on the ground. Your heart stops, no oxygen is being delivered to your organs. If it's your arms and legs and other organs, it may not be such a big deal right then and there. Liver, kidney is kind of an issue. You can have some damage to your kidney, but the big issue is blood doesn't get to your brain. Your brain is about a pound or so out of your 150, 160 pounds, but the blood flow to that small portion of your body is about 15 or 20% of blood flowing around. So if the blood doesn't go to your brain even for a short while, you lose neurons, you lose brain function. If your brain function is somewhat compromised to begin with, And for a couple of minutes, even with less blood going to your brain, you can imagine that's a big problem. And if you get through resuscitation, your brain may not get through in any form that you would like. So that's, I think, an important point. Um, if you start CPR, which you'll get demonstrated here, you're on a firm surface, as mentioned. People, and what'll happen is you wind up on the floor. Uh, if somebody is passing by and knows CPR, and that's whether you're in a restaurant, on the street, wherever it is, people don't go looking in your wallet looking for DNR forms or anything like that. If they know CPR and you're on the ground, they are going to start CPR. And they'll start by starting chest compressions. They push hard on your chest. That's not graded in any way. That's you push hard. If you're a small, frail person, they push hard. If you're a bulky, big sort of guy, they push hard. It makes no difference. It's the maximum force that they could push down on your chest every time. And if they'll keep doing that, and it does not stop. If they start, they are obligated to continue. If you're here and somebody starts that and EMTs come, they will continue. It continues until a doctor, presumably in the emergency room, either says, okay, we're done, there's nothing further to do, or you have established a heartbeat. If you do establish a heartbeat, then the most likely thing next to happen is you have a tube put into your lungs to keep you breathing. And that's the next step. So I think you've seen maybe do not resuscitate, do not intubate. If you're resuscitated and it's effective and you get a heart rate back, they're going to put a tube in there to get you breathing. Because the compressions on your heart will stimulate your heart. It's just physically pumping your heart, but it doesn't do anything for your lungs. And previously, when I was initially taught CPR many years ago, the method was to have 5 compressions and then you breathe into somebody's mouth. That wasn't too popular, got a little dicey there, especially with HIV and COVID, nobody's going to do that. And there's little gadgets that can be used to make it a little easier, but it's surprisingly been found that if you don't inflate somebody's lungs and just do the chest compressions, the results tend to be the same. So nobody does the breathing anymore, I don't think. They'll go into that in more detail. So the question is, what happens when this is all done? And that comes down to survival. And survival, if you read, there's lots of statistics on this. I've read statistics up to 10, 15% of people survive. That's really a stretch, I think. It's dependent on a variety of things. One thing is age. The older you are, the less likely this is going to be successful. The statistic I saw recently in the geriatric literature is if you're in your 70s, the chance of survival is about 2% if somebody sees you collapse, meaning they're right on you right quickly and things happen fast. If somebody sees you, if somebody doesn't see you and they find you and they start chest compressions, the percentage is less than 1% of surviving. And you might want to ask what surviving, besides age, I should say there are other factors, comorbidities. If you have lung disease, if you have Alzheimer's, if you have heart disease in the sense that your ejection fraction, the pumping action is down to 20% to begin with, or in that range, and you have been resuscitated, that range goes down a little bit, so your survival is even less likely. So age and comorbidities really are important to determine whether or not you're going to have a successful resuscitation. And the question is what successful means. You may, if you watch football, know that a year or two ago, a player collapsed on the field. That was witnessed by millions, but the people on the sideline got to him pretty quickly. They did CPR, and he did. I'm not sure he's playing football now, but he survived. Is he playing football again? He survived, but you may have noticed if you paid attention that he was not to be seen for weeks. He was in the hospital. He didn't get better right away. And this is a young guy, I guess in his 20s or so, peak of health, got resuscitated, and he still took him a while to get back. So you might imagine somebody older who got resuscitated and survived, meaning they got a heart rate and is on a breathing machine. So the likelihood is you would wake up in the ICU on a breathing machine, sedated, probably in pain because you've probably had 3 or 4 or 5 or 6 rib fractures because somebody's pressing on your chest real hard and you're older and fragile. So they're going to certainly break a few ribs. If you've had a broken rib, you know it's uncomfortable. So now you're on a machine and you got a half a dozen broken ribs and you're sedated because the machine is very uncomfortable. So that's how you might wake up if you survive. The survival rates are generally stated in terms of how many people survive for a month or so. And those are the numbers that I'm talking about, the couple of percentages. So the point is you generally don't do very well. So if you wake up a machine, if they take the machine off, you're still in the hospital for a good long while, and getting back to going out to dinner and enjoying life is probably less likely. So those are the statistics. Now it does, there are times that CPR can be effective. I had one patient in particular who was in his 70s. He had no other medical conditions except there was a problem with his heart rhythm, and his wife was knew CPR. She saw him collapse in the garden. She was on top of him in a heartbeat, so to say, and called, and he did reasonably well. He was resuscitated. He got a defibrillator implanted in his chest, and he went on for another couple of years. He wasn't quite the active businessman that he had been, but he did okay. So survival is limited. It is not, it does happen. It's limited if you have those conditions of osteoporosis or COPD, diabetes, heart disease, and you're older, your likelihood of surviving in any form that you would like to be is less likely. That's pretty much all I was going to have to say. Anything else to add?
Yeah, I have a couple of questions that have come up from residents that I'll just pose to you. And if you're not the right one of these ladies will certainly do that, and then I'll pass the mic. So how is any of this different if an AED is utilized?
The AED is the thing that restarts the rhythm of the heart. So that's an electrical. The electrical problems are a little easier because once you shock somebody and that ventricular fibrillation is resolved and they're in a regular heartbeat, that's in your favor. So it's helpful. The odds of survival are better. Still not great, but they're better. All the other things, the compressions on your chest, comorbidities other than electrical stuff is still there.
Okay, so I'd like to open it up to questions or comments for Dr. DiNapoli.
You mentioned the electrical and the heart muscle issues, but how does that relate to blockages? If you had a blockage somewhere.
You have a block. The relationship, I believe, is that what's going to trigger this if you have if your heart work, yeah, if you're what's going to happen to make you collapse and go to the floor, and it may well be a heart attack of greater or lesser extent, and that heart attack is related to the blockages in your blood vessels. So the blockages themselves don't have to do with chest compressions or anything like that, but they may precipitate the problem that causes it all to happen.
So it really may not make a difference, or it could bring on the event.
It could bring on the event that causes you to collapse.
Okay.
Yeah.
So it's definitely a contributing factor to a heart attack.
Yes, that is what will cause a heart attack.
And what?
That answer, does that help? Will not do that. No, no, nothing to do with it. Nope.
Is a heart attack contained only to when it's non-electrical or are both? The electrical and the other?
I think if you have, there's heart attacks that trigger atrial fibrillation and it happens and it's an unfortunate situation, but it happens.
Hi. My question is specifically about the most form. Okay. But to be honest, I'm a retired nurse practitioner that practiced in cardiology. So before I came up here, I made sure I went to an elder care lawyer and I had a healthcare proxy and all that stuff done. So my question is, if you're in good health, and why do we need a most form on top of the healthcare proxy and the what? The living will. So something came out and it said everybody should fill out a most form. All right. Now, if I look at the most form and the top of the most form doesn't really say it that way, it basically says, generally for patients with advanced illness who require long-term care services and who might die within 1 to 2 years. So why would a healthy person, I'm 75, fill this form out now if they have the living will and the advance directive already in place?
It's a good question that comes up. I have that discussion often in my office. I think that folks in skilled nursing, the most form is appropriate, and we always try to encourage that. The difference, the most form, if you know, page 1 has DNR and CPR, and page 2 has other directions. So if you wanted to specify do not resuscitate, and you check that box, you don't necessarily have to fill out the rest of it. And the most form is a legal document. Living will, to my understanding, is not necessarily a legal document and can be ignored. Most form cannot be ignored. It's a legal document. If you go to a hospital with a most form, the pink form, they see it, it's DNR, that's it, done deal. So I mean, I have patients that check the first button, do the first page, they draw a line through the second page, and that's the extent of their most, and I think that's reasonable. The other part of the most form, and I've heard one of the people that developed that form talk about it, and the way she said it was that the paper itself is about 10% of the process. The real issue is the 90% of it that you have discussions with your family and you think about what you want to have done. So I think going through the most form for that reason is valid. Having it down in black and white or pink and white, pink and black, whatever, makes it legal. And I still at times suggest to patients if they don't want to have that extensive discussion, because people don't want to have that discussion often, then at least the living will can elucidate their wishes. And if their healthcare proxy knows that a living will is available, then they can use that in times of emergency. Does that help at all?
And the healthcare proxy is a
legal document. Yeah, the healthcare
Okay.
proxy is a legal document. The most is a legal document. Living will is not a legal document. The most can just indicate DNR. And I think my understanding, I've never heard it proven, but my understanding is that is the only legal DNR in New York State, that document.
I'll add a little bit to that. So some of you may have attended when Anthony Emnowitz, the elder care attorney, came and gave a presentation on advanced directives. And his point, to Dr. DiNapoli's point, is probably the most important thing when discussing the most. It's really important that you have a healthcare proxy so that somebody can speak for you when you cannot. But it's more important that that person or people know your explicit wishes. And it makes it, so for example, my parents have asked me to be their healthcare proxy. I told them I would not do it until they filled out a MOLST because I can't imagine what they would want to do in that situation. They have to give me that direction. I don't want to be put in the position to have to put myself in your shoes. You need to make those choices. And the best way to do that is the MOLST form. And even if you don't use the MOLST form, use the contents of it and make your living will very specific. Because if you look at that, there are things on there about wanting, antibiotics, fluids, trial tube feeds, all these kinds of things. I would never know the answer of whether my father or mother would want that in a specific situation. I'm happy to dispatch their wishes, as I'm sure all of your healthcare proxies would be. But we need to take responsibility for those conversations and give them a roadmap. And Debbie and Tanya will talk more about the actual requirement to complete a MOLST in the skilled nursing and the assisted living environment. But here, the reason that we want them is because if you are found unconscious and unresponsive on the floor in independent living and you are a DNR, EMS knows to ask for your emergency packet. And then this way we can hand it to them and they're not going to start CPR if they have that completed MOLST form. So you may not know if you want fluids or antibiotics, but you may absolutely know that you do not want chest compressions and CPR. So you can, it's a little more nuanced. Betsy?
At the beginning, you said there was this, what he's speaking about has to do with skilled nursing. Huh? Okay, all right. Maybe my question is later. What is the difference there and here? Save that till later.
So I find somebody on the floor and I know CPR and there's a defibrillator machine on the wall. Which should I use?
I can talk about our defibrillator specifically.
All right. Excuse me. Are there really equivalent modalities to be used to restart the heart, or are there really significant differences of using one or the other?
They're usually used in conjunction, and usually you start chest compressions, and I'll leave those.
Yeah. Dr. DiNapoli is exactly right, and the ladies will demonstrate that. Other questions or comments for Dr. DiNapoli before we let him go back to his patients? Okay. Rolf, and then he said that Debbie and Tanya are going to go over it.
Just for interest, the person that did develop that form was Dr. Bomba, and she lectured, and she noted that at Thanksgiving dinners, they go around the table, everybody gives their wishes. You guys want to do that?
I'd just like to ask you a question if I did something right. I actually had a CPR incident that I had to administer. I'd taken a class in that, just a piece of background. So I was well versed of what it was, but this was probably 25 years ago.
25 or 3 to 5?
25.
25.
All right. And I've followed the rules. Turns out my neighbor had gone to Florida and they had just returned, driven in the driveway. And apparently as soon as the husband got out of the car, he went crashed on the ground. They sent the daughter over, knocked on my door. I went over, see what I could do. I could not detect any heartbeat or whatever of any kind. And so I started CPR on the guy. Well, I continued all the way till the time rescue squad arrived, and which was not that long. They were amazingly fast. But they never told me what the result was. They just drove off. About maybe a month later, I saw the gentleman who I put CPR on. The only comment he made was, "You hurt my ribs."
Hurt them? You didn't break them.
Very grateful.
Yeah,
So
yeah.
I do something wrong.
How do you know any details of his health or anything
No,
else?
no, I do not.
Yeah, because I mean, the statistics are such that they're poor for survival, but it does work sometimes. So, like I said, if you're a young, healthy football player, there was an interesting I guess it's just the movies, but James Bond had to resuscitate himself one time. I think he got poisoned. He went to his Austin Martin. He pulled the resuscitator out of the glove compartment, did it, got his tuxedo back together again, and went back in
So
and
he
finished
may
the
have had
job. But that's
osteopenia, I don't
not
know,
going to
or
happen.
osteoporosis. I have no idea.
Yeah.
Okay.
Anything else for Dr. DiNapoli? Okay. John, and then we'll let Debbie and Tanya do their thing.
This is a question about heart health since you deal with this age population. What is the most recent theory research on aspirin therapy?
It should be used with specific problems in mind. Once upon a time, it was everybody take a baby aspirin. That's no longer the case. Now, if you have heart disease or other specific reasons to take it, you take it. If you don't have those specific reasons, you don't.
Thank you so much.
Thank you.
Thank you. Yes, you pass. All right, so Debbie Vining, our Director of Nursing, is going to talk to you a bit about what happens when you arrive in the health center and the MOLST form, and then they will take it from there about a code blue and CPR.
Thank you. Hello, everyone. So first I want to say when we have new residents arriving in the health center, we always show them this. Usually it's social work who starts the process, but sometimes we don't have a social worker available at that time, and nursing will take over within the first few hours of you arriving to the health center. Whether it's assisted living or memory care or skilled, we do use the MOLST. As you've seen, I'm sure a bunch of you have seen these before. So with the MOLST, we do go over if you want to be a CPR or a DNR at that time. We do have residents who come in who at that time really are undecided. They will tell us, you know what, I don't know. I really want to think about that. When that happens and they don't want to fill one of these out, we do let them know that you are then a full code until this is filled out. A full code means that we will perform CPR if you become unresponsive. So we always really, really like to stress at that point what happens with a full code. Our nurses are trained to have those discussions with residents. We explain the process, which we will explain with Tanya in a few minutes. I also want to go back to what Dr. DiNapoli said about a DNR, that I think a lot of times residents will say to us, even family members will say, well, if I'm a DNR, you guys are not going to do anything. You're just going to leave us in a room. That is not the case. With the MOLST, it does have a lot of things on there, and you can also add things of your wishes. We go over that. You can have antibiotics, you can have IV fluids, tube feeding if you want to have that done eventually. If something came up where you need to have a tube feed done, we'll send you out to hospital, obviously, and they will start that procedure. You could also add on there if you want dialysis or not dialysis. So there's multiple things that can still be done. Does not mean that you're a DNR and we just put you in a room and that's it and we don't treat you. That is not the case. We do have residents that come in, though, that request no antibiotics, no IV fluids, no dialysis. So we do have residents who really wish to just come in there and be comfortable, and that's it. And that's okay as well. So when you come onto the health center, this is really, really important. We put those orders in immediately when you get there. The reason this is so important, because we can have somebody who comes in the first hour go unresponsive. So what do? If this is not filled out, we automatically at that time call a code, which we'll go over in details how the code works. When the ambulance gets there, or when we send you to the hospital, this is what goes with you. This is why this is so important. The hospital has to have this. If they do not, they're going to treat you like a full code, regardless. Okay, so that's why this is really, really important. This goes to the hospital and we keep a copy. When you come back from the hospital, if you come back, we get a copy back of that. We do every year go over the MOLST. Social work does that, or nursing. And then at that time, the Dr. DiNapoli will also review it again and sign off on that. So when there is a code, which means, say I'm walking by and I see Mr. Smith on the floor. I'm going to run in there. I'm going to check Mr. Smith and make sure if he doesn't have a pulse, he doesn't have a heartbeat, we call a code blue. A code blue then is announced throughout the whole health center. And at that time, immediately, as soon as I see that person, I'm yelling for help, but I'm going to start CPR. That would be, yep. Only if they're full code, correct, sorry. Yes, only if you're full code. Yes, sure, yeah. So on our unit, if you're full code, well, we always have the moles first. So if you're DNR or full code, it should be on your moles. If you are a DNR, we do have a thing on a sticker, a red sticker on your door. We also have it on your chart, and we also have the moles. So this will all be checked. We also check every day. The nurse will have a list. They do have a list of who's a DNR, who's a CPR. So we will know that pretty quickly, who's a DNR or a CPR. And bracelets, yes, correct. Your bracelets also will have the red dot on it. So with that being said, once you confirm that they're DNR or CPR, we will perform CPR if they're full code. At that time, a code is called. When that happens, you will have tons of people coming into that room. We get a crash cart, lots of nurses will be there. We'll have a whole team there. And at that time, a 911 is called immediately. And I have to say, they're pretty good. New Pulse is here within like minutes. So I'm going to actually just kind of go over more CPR if Tanya would like to come up here. Tanya actually does our training for CPR in our building. So she is a certified instructor for CPR. So we're going to just show you a little bit. I'll talk if do you want to talk first? You want to go over a little bit of CPR first?
Good morning. So the first thing that you have to do is, when you see somebody, especially if it's in the skill, if it's in the bed, you not necessarily have to put on the floor because, as soon you find out that the person doesn't have pulse and is not breathing, which is the first thing that you have to do, you have to yell and, look for help, activate the emergency, response and ask for the AED and the emergency card. So the emergency comes with a board that you can turn the resident, put that board underneath because they really need this hard surface so you can pump, hard. And you can regulate the bed. So at the height that you're going to need enough, to have that force to bring, and do the resuscitation. So, Min said that, the first thing that you need to check, again, you need to go for the pulse. If you go and see the trachea, you go in the side of the trachea over here and you will feel the pulse. That's the one that you're going to need. And then if it's breathing. So sometimes you will hear like a gasp noise. That's not irregular breathing. That is a problem. So they really need to be resuscitated. So now I'm going to go and I'm going to show you, exactly what you have to do.
So at this time, if we are performing CPR, yep, sure. Sure. Oh yeah, because it blends in. Yep. Yep. Sure. I do want to point out too, because a lot of our codes in the health center, when you do have a code or in long-term care, because I've been doing this a long time, all the codes I've ever walked in on, I've only actually witnessed twice the actual resident going down. So what that means, as Dr. DiNapoli is saying, we have no idea how long that person has been out. So I just want to clarify that too. All the times I've done CPR, which unfortunately I've done a lot of CPR, only 2 times I've actually witnessed literally someone dropping and performing it. And in those 2 cases, both of those people still did not survive. And we started CPR immediately. No, I have not had anyone survive it. I've had 2 people get a pulse back and their heart beating. But the time that paramedics got there, they coded again. I have never had someone actually survive it yet. And I've done CPR from ages 30 all the way up to 101. And I've not had one person survive it yet. And that's actually witnessing somebody falling and starting it immediately. So I just want to be clear on that too.
And another consideration that you need to have is that, when you're doing CPR, you need to actually press, very hard. Needs to be like a 2 inches deep. And remember, when you do that, you can break, bones, you can break, ribs, and you can have lungs, perforation. And also think about, people that are in accumulating any blood thinner, and you're going to be internally bleeding, because you're going to be breaking. Yeah, you're going to breaking, some of these ribs.
On that note, when she's talking about that, and I am going to be a little graphic here, of all the CPR I've ever done, I've always broken ribs. You hear them crush them because you have to do it with that much force. So sometimes it will put a hole in the lungs. It could put a hole in the heart as you're doing that. And also internal bleeding if they're on Coumadin or Eliquis or blood thinners, which a lot of our population's on blood thinners. It's a very traumatic thing when we do it. I'm going to have Tanya show you how hard that we're pressing. Mhm. Yep. So at this time, we're going to see if the person is breathing or if they have a pulse. Yep. Yep. So at that time, she's going to yell for help. And I'm going to come with a crash cart. We're going to call a code, and multiple staff respond. CNAs and nurses do respond. At that time, we're going to grab the AED, which is this right here. This is obviously a training one, but at this point, we'll start compressions first. 30 compressions? Yes. Yep, 30 and 2. So she's now giving them breaths, and then 30 again. Yep. Oh, sorry. Yeah, look up there. You could probably see it better. Let me get out of your way a little bit. So those will be on the crash cart. On our crash cart, we have ambu bags, they're called, when that's where it helps us so we can breathe through so we're not touching, making contact. Also with CPR, sometimes when we're doing CPR, the person will have stuff expel from their mouth. So you do not want to put your mouth there. That's why we use the ambu bags. There will also be IV stuff because sometimes we do start an IV if we can. That helps the paramedics when they get there. If we can get the IV started, if we did get a pulse, they're going to want to start some kind of medication quickly. We also have the board. We have the AED. So the AED, she's going to apply it now. And again, this really only works if it's electrical.
When you bring the AED, it's a second person. So even though you still continue doing CPR while the person is putting the patches. And if you see the patches, it's actually telling you where to put them. And we have 3 AED over here in Woodland Pan. One is going to be in the concierge. The other one is upstairs in the assistant living in the great room. And the other one is in the reception in the health center in the reception. Yeah.
Reception health center is the last one.
And actually the AED is going to tell you exactly what you need to do. You need to listen because it's telling you step by step what you have to do. So the first thing, you take it off while the other person is doing the compressions, and then you just turn it on and you're going to hear it.
If the patient is a child, press the child button. Remove clothing from the patient's chest. Remove packet and apply pads onto patient's bare skin. Press pads firmly on skin. Press pads firmly on skin. Do not touch the patient. Analyzing.
So that's important for us. It will tell us to step away at that point because we can be shocked if we go near the patient.
Everyone clear.
We'll yell clear and make sure no one's touching the body at all.
Shock delivered. Begin CPR.
So the AED will tell us if it got anything. So it'll tell you when to perform CPR and when not to CPR. we cannot stop performing CPR until the paramedics get there and then they take over. The paramedics at times will have us continue because they're doing other things like getting IVs and things like that ready. At that time, depending how long the person has been out for, sometimes they will call the ER, and they will talk to the ER doctor. That ER doctor can make a decision to stop CPR. We as nurses in the health center cannot make that decision. Our job is to continue CPR, and we have to do that. We cannot stop until paramedics take over or it's called by an MD at the emergency room. I think that was good. Did everybody see that? So it's hard to kind of envision, but when I say we're doing it with force, it's full force. And we rotate each nurse every few minutes because it's exhausting. Very exhausting. Sorry, I thought I lost the mic for a minute. Yep.
If there's anybody that would want to try, you can come up and try when we're done. We can put it on the table probably for that. And then that way you can try and Tanya can let you know if it was hard enough. So I'd like to give you an opportunity to ask questions of Debbie and Tanya. And thank you very much for
You're
this.
welcome.
It's been, I think, very enlightening for a lot of people. I think that a lot of people think that once the AED is involved, CPR stops. But as you could hear from the AED, it's telling you keep going with the CPR. Does it ever shock more than once?
Yes. Yes. They have a rhythm. It will shock again.
If it finds it. So it's continually analyzing as you're.
And it will tell you, and then it will tell you to stop CPR as well.
And then it'll say clear again?
Yes.
Okay. Some questions, please.
Okay, same question. What's the difference in the health center and independent living?
So health center, we have nurses over there, so we are under different, obviously, regulations. Over here, you guys are independent. So the ambulance would be called, you could probably speak a little bit more on independent, but health center, it's our responsibility as the nurses over there to start it and perform it and make sure that the most is done in the health center.
Right, so the most is required. That's step one in the health center.
Yep.
It's optional, but recommended in IL. The staff in the health center is required to comply with that most form and act on it. There's not a nurse, unless she does dereliction of duty or he, that cannot participate in that CPR. So they're required under their licensure to begin CPR in the health center. In independent living, it's Good Samaritan, with the exception of Angel and MJ, because they are registered nurses and they are here hired as nurses. So they would be required to begin CPR if they found somebody down. We have a little bit of a wrinkle right now because some of you have taken the opportunity to get a DNR sticker on your badge, in which case we have to have the most form, and you need to understand that it's still going to be somewhat in the eyes of the beholder because it's not regulated like this, but at least it tells your story. But in that case, they have to keep going until EMS gets there. In independent living, it's not a medical setting. It's not a clinical setting. So unless Mary Jo or Angel is the one that has responded to you as an RN, anyone else can stop at any point in the process, or they can just leave you on the ground. It's just as if you were in ShopRite.
Right.
Deborah?
This is really revelatory. This has been very useful because I was reluctant to contemplate a DNR because I'm only 75. There are a lot of folks who are much older than me in independent living. But now that you have described the horrors of CPR and the tiny little fraction of people who survive it, I want a DNR.
DNR, yep.
Thank you.
You're
This has
welcome.
been very helpful.
And again, I think that people don't realize how traumatic it is. And I'm glad that we had this opportunity to explain it a little bit more.
Before I take your question, Ronnie, I also just want to express to you that it is, I don't know what your experiences have been, But I've spoken with nurses at Woodland Pond that have been extremely traumatized by their role in a failed CPR attempt. We've had situations where because EMS could not get here quickly, our nurses have had, we've only had to do CPR here twice or 3 times maybe. One was recently. The staff was able to get a pulse for that person, and then the person coded again quickly thereafter once EMS had already intubated, right?
Yes.
So they were able to get a pulse. The person technically was resuscitated, but then quickly coded immediately thereafter, and then that was it. In the ambulance, I think, or
Right.
on the
And,
way.
and
to
I'm
the
going to just
ambulance.
touch a little bit on that as a nurse, and I'm sure Tanya can speak for this as well. When we're doing those codes, obviously we're doing everything we can to save you because that's our job. We care deeply about our residents. So when we're doing that after the code is done and we have lost that resident, it is a huge, huge, huge traumatic thing for all of us. So we don't go home at night and saying, oh, we did, we always want to do better. We always think it wasn't enough. And that is really hard for us. We become very attached to our residents and we always want to save everyone if we can.
And it is physically exhausting.
Yes.
So one of the circumstances when EMS couldn't get here quickly in the health center, our nurses had to perform CPR, 2 of them. They were the only 2 that were available at the time. This was many years ago, 45 minutes of chest compressions. And in this particular case, the person was on a blood thinner. And when that happens, there is blood that comes out
Yes.
of certain parts of
Yes.
your body,
Mhm.
just from the force and the pressure. It is, and it's very hard on the staff. So there is a lot to it, Deborah, to your point. Who
And-
else has a question or a comment?
It is. It is. Yes. It has to be to try to get your heart to restart. Yes. It is violent. Yes.
Ditto. But I just had a question in the health center. You said you have an AED in the great room and in the reception desk. Why don't you have them on the units?
Well, we would automatically start the CPR right away. So that's the first thing you're going to do, your compressions. At that time, there's a nurse who's going to run and just get the AED. So within seconds. Yeah.
And the units are such that if we had them, inevitably the code would be on the other end of the unit.
Right.
And reception is
Right.
right there and it's centrally
Yeah.
located. Then it's also available for anybody that walks in the door or.
And priority is always going to be compressions first. That's priority.
And as you could see, compressions continue throughout.
Mhm.
Another question or comment?
If a person chooses a D and R, nothing is done?
No CPR is done. We do not do we do not do compressions on them. No. Now, if you're sick and you're not feeling well, we will still give you antibiotics, IVs like that. But if you are unresponsive, no heartbeat and no pulse, we will not perform CPR on you. At that time, as the RN, I will have to pronounce you. The RNs in the building on health center pronounce people when they pass. So it would be me or another RN that would come in to do your assessment, and then we pronounce you.
Can you just repeat the things that have to be present in order for you to begin CPR?
Yes.
They have to be what?
You have no heartbeat and you have no pulse, which we would be checking over here by your carotid. We also will check here. We'll check multiple areas to see if we get a pulse because sometimes people have really, really faint pulses when they're unresponsive. You would not be breathing, no heart rate. Now the breathing thing, sometimes people do get a little panicky because what happens is sometimes when people are out for a long period of time, they're unresponsive. We might have not known how long they've been there. You will have some air. So when we're doing compressions, the air will come out and it sounds like you're breathing, but you're not. It's just air.
And the nurses are trained to know the difference.
The difference, yes. Mhm.
I've been using the term flatlining. Is that the same thing, or does that mean you have to be hitched
Yes.
up to a monitor?
Yes. Yep.
So if you're hitched up to a monitor and it goes flat.
It's flat, yeah. And when the paramedics come, they will hook you up to a monitor. They do that. Mhm.
So flatlining.
Yep. The paramedics automatically hook you up to something because they have to show that to the emergency room doctor as well. I've been in cases where 45 minutes to an hour of performing CPR, the paramedics finally get there. They still have to do that. And we know that they're gone. We know that, but we have to continue. And then they have to send the actual strip showing. It's a EKG machine they put on them, yes. And they send it to the ER doctor. and then he pronounces. Yep.
Tanya, who on our staff in the health center do you certify for CPR?
So in the center, we all have, all the nurses certified. They are, they have, CPR, and they also, some of the aides, but however, by the policy, they cannot perform, they can help, but they cannot perform the CPR. Has
They
to be
can't
licensed
initiate
like
it.
nurses,
They
yes.
can initiate it.
All right, so a CNA cannot
They
initiate
cannot
CPR?
start CPR because it has to be an LPN or RN because we have to make sure that that person's unresponsive. A CNA is not qualified for that.
So can they participate?
They can help. Yes.
So they can be one of the person that swaps in to do chest compressions?
Right. We usually would not have a CNA do chest compressions.
Okay.
They will
Okay.
help us with everything else, make the calls,
Okay.
do all that stuff.
And do we have nurses in the health center 24/7?
Yes, we do.
Okay.
Yes.
I already knew the answer to that question, but I wanted you.
We actually have really great staff and even on night shift. So there's going to usually be at least 4 nurses even on night shift, which is amazing because if you have to do CPR, you're going to want a team. I can assure you that because after 5 minutes of doing those compressions, you are exhausted.
So this makes me a little nervous as a bystander who walks by and sees somebody drop, that it can do so much damage if I intervene to do something and that person died or suffered some kind of horrible health problem. Where do I stand? Do I get sued if I'm independent?
No, it's a good Samaritan law. Just like if I'm walking into on IL or if sometimes we take walks around the building. If I saw somebody on the ground, we automatically would run over there and check and we would start CPR. Absolutely. Yeah, yeah. Right, you're not expected to. That's a choice. That's a choice.
And
Yes.
I see Michelle is
Yeah.
gone, but she's, questioning why would I want a MOLST?
Mhm.
Here in particular, we want them because we want our staff in independent living and the receptionists and concierge to know what your advanced directives are. Because it isn't always the case. And many of our residents have DNR orders. If you do not want to be resuscitated, you really don't want to be resuscitated, right? And you don't want to wake up in a sedated state and being intubated and broken ribs, most likely cognitive impairment because you've had no oxygen flow to your brain.
And that's a decision then too. I would like to bring that up since you're bringing it up. So if you do survive and you get a pulse, we obviously send you out and have had this happen. They're then put on ventilators. So you're not able to breathe on your own. And then it's your family that has to usually make that decision to stop that. So I always bring that up too, because imagine having one of your children make that decision who didn't know your wishes and how they feel.
Right. So filling out that MOLST
Yeah.
or having those
It's
conversations
really
is
important.
extremely
Mhm.
important for your family and loved ones. June and then Taylor.
May I now throw away my healthcare proxy and my living will that I've filled out the most form?
No, do not throw it away.
Explain
Yeah,
that.
go
So
ahead.
you need the healthcare proxy because the healthcare proxy tells us who speaks for you if you can't. No, it's not in the MOLST form.
Mm-mm.
It might be, but it's duplicative. You absolutely have to have the healthcare proxy
Sure.
and
Let them look.
MOLST is recommended. The living will you can get rid of.
I'll leave the MOLST up here too, so they can come and just look at the MOLST too afterwards if you want to come look at it.
Yeah. The other question was, I didn't
Information.
quite understand how you start the AED. I mean, do you have to like open it or wasn't clear?
Tony can show you when you
Okay.
go up, but there's stickers and it talks you right through it.
So as soon you open it, the first thing that you need to do is just to turn it on, the first thing. So actually the AED is going to tell you step by step what you have to do. Yes, it's a button, it's a green button in the middle. You're going to see it's a different one that we have in here, but you will be able to identify which one is the power button. So you push that power button and automatically it's going to tell you exactly what you have to do. They have to tell you, like take the clothes off, take the pad, how you have to peel it, take the first step, take the other pill. So it's a step by step. Now you need to listen. And it's important when you start, doing the CPR and the AED is telling you stop, you need to stop because if you get shocked, you can die. So when they tell you it's in clear, it's telling you several times before, tells you to push the button for the shock because you're gonna push the button, but you make sure that anybody that is around, everybody that's around has to be separate and nothing is touching the patient.
You can't even be touching their toe because that shock will shock your heart.
Push, the button that is flashing, that's the the shock. You just push in there and then it will deliver the shock. Yeah.
They're bigger too. They're big. Yeah.
Yeah. So the ones that we have at concierge and reception and great room are a little bit more sophisticated even than this one. If you were to look at it, we purchase ones that tell you that they're right at the front. There's a green light at the front that tells you this is ready to go. So it means it's been maintained. It has a self-diagnostic feature that it runs diagnostics on itself continually. And then it has a green button that tells you it's ready to go. As soon as ours get opened, because this is just a training one, as soon as the ones that we have in those other 3 locations, as soon as the case opens, it tells you exactly what to do. This one isn't as sophisticated. We spent significant dollars on getting the ones that are basically dummy proof. Taylor?
Okay, 2 things. First of all, I am a fan of DNRs, and one thing that you haven't, that no one has mentioned is that there are all those physical things, but the likelihood of your being resuscitated and your brain functioning fully is slim to none. So that's, my husband always said no person he knew with medical training wanted to be resuscitated because they knew how chancy it was. The other thing, though, is that if you, and I have had this direct experience recently, when you go to the hospital and you're going to have some procedure and you have a DNR on your most, they will go over with you whether you want to keep it there given these particular circumstances. And I had the surgeon say to me, my son is standing there with me. He's my healthcare proxy. And he's saying, no, she does not want to be resuscitated. Now, this is because we have a family experience and know what the outcomes can be. And he explained, well, the only reason you would have to be resuscitated because we're operating on your ankle and everything about you is really healthy are these things. And I think maybe you should change it just for the procedure. And tomorrow morning, I'll come into your room and we can reinstate the DNR. I mean, he just said, you can undo it right now for this procedure, but you can then change it back if that's really your desire. So I'm saying you're not stuck if something.
Right. You can change your most at any time. But to your point, Taylor, you're lucky they gave you a choice because most times we see if residents are going out for any kind of a procedure that requires anesthesia, they will require you to revoke your DNR.
Oh, well, I had a nice surgeon.
Yeah. Most surgeons and anesthesiologists will require you to revoke your DNR for a procedure that requires anesthesia. So you should be prepared for that. And then you reinstate it once you are, through the surgery. Can a healthcare proxy complete a MOLST on behalf of someone that is not cognitively intact? So like if I come in and I have dementia and I don't have a MOLST and social work wants to talk to my daughter, they can do that.
It would be your healthcare proxy who would fill out your form if you're unable to do so. Yes. That's why it's important, whoever your healthcare proxy is, knows your wishes. Because I will say that I've seen your healthcare proxies reverse what that person's wishes were. And that's rough to see, but there's nothing we can do because you're the healthcare proxy at that time.
We've been told that our doctors have to sign off on the MOLST, but when I read it, I thought it just said that the doctors have to sign if you're mentally incompetent.
In the health center, our doctor signs off every MOLST.
But we're an IL. Do we have to have
Sure, on the bottom, they still will sign it. I would always go over it with your doctor and have them sign it. They should know your wishes because they're going to talk to you and have that communication with you too. So I would have your doctor or your NP. You can have a doctor, NP, sign it. Who's next one?
It seems to me with the kind of compression that is done with CPR, if someone has bad osteoporosis, it would definitely not be a good idea because it seems that your internal bones, everything would really
Your bones will crumble.
crumble.
And I've had that happen. Yes.
We'll go to Leah, and I think we'll wrap it up. And you guys have done absolutely fantastic.
Thank you.
Thank you so much.
And we would like to keep this stuff up here for a few minutes if anybody wants to try it.
Yeah, I have a question. How many times you need to sign the paper? I signed once when I
Well,
was
in
in the health
independent
center.
living, usually it'd be just once, or when the doctor, you're like physical with your doctor, they'll go over it with you yearly. In the health center, we do it yearly, or whenever you want to change it. I do want to, Taylor mentioned that you can change it at any time, especially at the health center. We have nurses 24/7 on the health center. So say maybe 3 o'clock in the morning, you're thinking about it and you're a full code and you're like, I don't want to do this anymore. You can go to that nurse and say, I want my mulch changed, and they can change it to a DNR. And then we have the MD review it when he comes in.
A second question. If I am in the floor, how the person that is going to find me knows that I don't want to be resuscitated?
So Debbie explained how that works in the health center. They have you have a bracelet on that
Bracelet,
tells you what your wishes are, but in independent living, you don't unless you have the DNR sticker here on your badge and you're wearing your badge. Otherwise, here, no one's going to know. Maddie, did you have a comment?
There's something that has just happened where we're expected to do it again. We're supposed to redo our mulch forms because of, okay, so I think you need to say that.
It was a requirement for the pond. It's not.
Oh, the hell with that then. For a 5% chance of surviving? I don't think so.
1 to 2. 5 was the best.
That's the best.
All right, Artie, and then we're going to say goodbye and thank you to Tanya and Debbie.
Suppose you're walking on the campus and you're on the new trail and you have the
Furs, yeah.
and you fall down on the ground and you press it. What is the time interval from that sound going to? It doesn't work on that trail? At the trailheads. I see.
So bring your phone on the trail.
Yes, bring your phone on the trails or get the cellular PERS from concierge. All right. Or yes. Nothing's infallible, but all right. If anybody would like to come up and thank these ladies, or let's give them a big round of applause. If anyone would like to give your hand at trying these chest compressions, come on up. Otherwise, I think you guys did an awesome job and this has been great.